Good evening, everyone. Today's topic is 10 lessons to remember when treating a patient with glomerulonephritis. So I'd like to welcome you all into AHN Fireside Chat, the nephrology webinar, and today's series number 95. So before I proceed, I would like to read a short bio of Professor Jadoul. Professor Michel Jadoul received his MD degree in 1983 at UC Louvain in Brussels, Belgium. His mentor was Professor Charles van Ypersel. He further spent a year in Utrecht, the Netherlands, under Professor Dohart, Mies, and Koemans. He's chairing the Department of Nephrology of the Critique University, St. Louis, since 2003, and is a full clinical professor of medicine at UC Louvain. His clinical activities include the follow-up of hemodialysis and CKD patients. His main research interests have included hepatitis C, beta-2M amyloidosis, and other complications in hemodialysis patients, drug-induced nephrotoxicity, as well as cardiovascular complications after kidney transplantations. He has co-authored over 330 scientific papers, most of them published in major nephrology journals. He's a theme editor of nephrology dialysis transplantation. He's a country co-investigator for the Dialysis Outcomes Practice Pattern Study, DOPS. He received in 2008 the International Distinguished Medal of the National Kidney Foundation. He has been a member of the European Renal Association Council since 2013 to 2016, and is a co-chair of Kidney Disease Improving Global Outcomes, KDIGO, since 2019. So it's a great honor and privilege to introduce to you Professor Michel Jadoul. Right, Professor Michel Jadoul, you are welcome, and please proceed. Thank you.
Thank you very much for firstly the invitation, and secondly the kind introduction. I'm more than happy to share with you firstly hopefully my slides, and secondly my experience as shown by the presence this evening of one of my recent PhD, no longer students, PhD doctors, Dr. Manix Masimango from Bukavu in Congo. We have had a number of fellows for historical reasons. We have had a number of fellows, very good ones, from especially Congo or Burundi. And I've gone personally to quite a number of sub-Saharan Africa countries. So I would like to go back again as soon as the pandemic will make it easier to travel. So I'm more than happy, I accepted immediately. I'm more than happy to share with you my experience in the follow-up of patients with glomerulonephritis. I guess you can see my slides moving if I don't hear anything. Now my disclosures, the main one is that, as already mentioned, I'm since 3 years now co-chair of KDIGO. And that being said, it means that I'm expected, if I may say so, to be one of the typical representatives of so-called evidence-based medicines, guidelines, systematic reviews, and meta-analysis. And yet, I will show you this evening, or present today, a talk that is rather unusual. In fact, more than 3 decades ago, my mentor, whose name is on the slide and was already mentioned by the president of the session, my mentor, Professor Charles van Ypersel, asked me, and that was clearly a mandate, to learn rapidly to perform kidney biopsies, because a colleague who was in charge of that in the hospital would leave and go to another hospital. So I was really asked to learn rapidly how to perform kidney biopsies. And during 2 decades, I performed virtually all kidney biopsies on native kidneys, meaning something between 900 and 1,000 kidney biopsies, and have discussed their results with the nephrology team. I learned a lot with the colleagues. My mentor on the left-hand side, Professor Charles van Ypersel, who has been both a member of the ERA Council and of the ISN Council. In the middle, my predecessor as head of nephrology division, Professor Yves Pirson, who has been a president of the French-speaking society. And on the right-hand side, you have Jean-Pierre Cosens, who has been the professor of nephropathology at my hospital for a long time. He's now emeritus for a decade or so. So over my 34 years of nephrology training and practice, it was obvious for me from the onset that glomerular diseases are an excellent teaching model to understand how best to use a key organ for the benefit of kidney patients. Now you may wonder, what is that organ? Well, the organ is shown at the bottom of the slide, and I have two examples, but I could find many slides on the internet. It's of course the human brain. Whenever you care for a kidney patient, especially someone with a complex disease, and many glomerular diseases are complex, are not easily predictable, you have to use in the best possible way your human brain. And I will try to give you a few lessons that may help you in your clinical practice. The basis of this talk is that I will use some case histories. Of course, on some topics there is evidence, and evidence ideally is RCT, randomized controlled trial based evidence. But still, in many cases, you don't have RCTs, or the evidence is not based on trials, but is based on pathology, on interpretation. Of course, if you disagree with me, please do not hesitate. There will be certainly a time at the end for Q&A, but I'm convinced that what I will say is correct, and that there is a potential benefit in keeping in mind what I will tell you this evening, and that there is potential educational value for you, as I've learned from my errors. So I've had to learn what I will show today. So modern medicine, many decisions are still based on, of course, some science, ideally RCT evidence, but also a lot of art or sound reasoning logics. Let's start with the first piece of the puzzle, and you will not be surprised when I discuss glomerular diseases that I start with the kidney biopsy. And of course, a kidney biopsy is very important in many cases. You should analyze whenever possible, and I understand that not everything is available everywhere. That's beyond, let's say, the scope of this talk, but we can discuss that subsequently if you want. But you shouldn't analyze by light microscopy. That's relatively easy if you have a piece of kidney, and by either immunofluorescence or immunohistochemistry. We prefer in Brussels the immunofluorescence, but technically it's maybe more cumbersome. I think a good immunohistochemistry may be right as well. The procedure should be standardized, and you should use multiple staining, silver staining, PAS, HES, and so on. A few things I have learned over the years. Number one, if the sample size of the kidney is very small, you have a single glomerulus. For some diseases like FSGS, focal segmental glomerulosclerosis, usually you can't say anything. But on the other hand, if you have a single glomerulus, and this one can be analyzed by immunofluorescence or immunohistochemistry for a diagnosis of membranous nephropathy, you don't need anything. You don't need 5 or 10 or 35 glomeruli. You just have the right diagnosis if you have by immunofluorescence granular membranous deposits of immunoglobulins along the basement membrane. Next comment is that if the diagnosis after the biopsy remains unclear for you, and that happens in Brussels as well, definitely, you may consider to request a second reading by an expert in another city or in another country. We have been fortunate to have from time to time the help of people either in Paris, the group of Pierre Ronco, or in the Mayo Clinic, the group of Fernando Fervenza and Sanjeev Sethi. So we have had help from top experts. I'm interested by glomerular disease. I've seen hundreds of patients with various types, but still I'm not the super expert, and certainly not in the complex reading of biopsies. But the first message is just the diagnosis of correct diagnosis of a glomerular disease is crucial, and this does worth efforts. And efforts may mean second opinion, second reading, multiple stagings, sometimes a second biopsy. Now, the biopsy is, of course, very important. Is it always the gold standard in diagnosing a glomerular disease? I think the answer is no. There is no test in medicine that is 100% sensitive and specific. And I just show you an example from my recent clinical practice. A 35-year-old hypertensive male with a chronic proteinuria, 5 grams a day, and microscopic hematuria. He originates from Morocco, but lives in Belgium, and comes to me for a second opinion. And he brings to me at the outpatient clinic a report of the biopsy saying nephrosclerosis, because there are mild vascular and tubulointerstitial lesions and no glomerular lesions. Now, he did not mention that, but when asked, he mentions to me that he has a sister that is living in Morocco that also has microscopic hematuria and proteinuria and a glomerular filtration rate around 30. She had no biopsy yet. I think you will agree with me that because of that critical family history, I may revise the diagnosis to a glomerulonephritis. There are no visible glomerular lesions on the few available slides, probably a sample size problem. It looks like a recessive Alport syndrome. We know that in North Africa, in many areas, remote areas, there is a lot of consanguinity. Genetic testing is not yet available, but this important and highly suspected, not yet final diagnosis, of course, important clinical implication. So a second point is no single test is always the gold standard in medicine. A result like a biopsy report not fitting with the whole picture, here the urine testing and the family history should not be given too much importance. And as said on this picture from the internet, which is of course a joke, of a guy saying, I already diagnosed myself on the internet, I'm only here for a second opinion. You should consider the whole picture and not just the single conclusion of the pathologist. A nephropathologist may be wrong as well. I will present now a second case that came to me for a second opinion, and again highlighting that the whole picture is critical. It's a 66-year-old female with a serum creatinine of 1.7, nephrotic proteinuria, 5 grams a day, no hematuria, ultrasound of the kidneys unremarkable, no diabetes, nothing, no clue to anything. Kidney biopsy performed at another hospital showed focal lesions suggestive of FSGS, some arteriolar lesions, and some squamous cells. So the conclusion of the nephrologist at that hospital was FSGS, very likely primary. He started steroids, then cyclosporine. What happened was what you can expect, a lot of side effects. That does not mean that I do not prescribe steroids or cyclosporine, but at least that lady had a lot of side effects and no remission. She came to me for a second opinion, and I realized when she came to me, I had a detailed look at the whole files, dozens of pages, that at the time of the biopsy, there was no edema. The albumin level in serum was perfectly normal. So that is very unusual for a primary FSGS. And when looking back, I was able to find in a medical history in yet a third hospital, a urine test of 5 years earlier with already 5 grams proteinuria. Thus, again here, I revised the diagnosis to secondary FSGS, probably genetic. Again, I don't have yet the final diagnosis, but be genetic or nephron reduction. There is no evidence in this case that this is primary FSGS worth immunosuppression. Now, I've shown 2 cases where I changed the diagnosis, but everybody makes errors, and at my hospital it happens as well. I will show such an example. A lady I'm still following nowadays in 2022, she's doing well. in 1978, she came at the outpatient clinic of my mentor, Charles Van Ypezel. No, sorry, she came in 1980, 42 years ago. But she had proteinuria found at an insurance testing in 1978. And in 1980, she had, let's say, glomerular proteinuria, 2 grams per liter, mild hematuria, 33 red blood cells per microliter, and some edema. And the conclusion of my mentor was, of course, as you can imagine, nephrotic syndrome. And he requested a kidney biopsy, and the pathology diagnosis was minimal change disease. He started quite logically corticosteroids, and here is the evolution from left 1980. These are from his files, and I followed up that patient from 2003. I will show the full evolution. So the lady had proteinuria between 3 and 4 grams a day. It fluctuated, and she got steroids during, let's say, 7 to 8 months. As you can see, you may have the impression that something happened, but then the proteinuria again went up. This is all except a typical evolution. There was no complete remission. This is a young adult, and you would have expected a complete remission of the steroids and not a partial remission as shown here. So when seeing that, but it's always easier to have a look back than to see prospectively. When seeing that, when I started the follow-up in 2003, I thought this was a distinctly unusual minimal change. Yet, she did well, and as you can see, eventually the proteinuria disappeared in 85. Then I thought this is a very slow impact of steroids. Coincidence between the remission and the steroids, I cannot exclude that. Okay. In June 2000, so she had 15 years of honeymoon, if I may say so. In June 2000, she had a relapse of proteinuria, 4.4 grams a day with mild hematuria. And in 2003, again, proteinuria, subnephrotic. And my mentor started cyclosporine, the trade name in Europe being Neoral. And I started the follow-up in 2003. And whereas under Neoral, the proteinuria was okay, let's say below or around a gram a day. As you can see, initially I was not very successful. Under cyclosporine, her proteinuria went up from 1 gram to 3 grams. So I thought, again, I do not understand very well what happens. And she was reliable. The cyclosporine trough level were perfect. She took the whole sequence of medication was expected. So I thought, I will reduce the immunosuppression. She does not seem to respond well. And I will start anti-proteinuric treatment with an ACE inhibitor, perindopril, and thiazide, indapamide. I added subsequently furosemide, a loop diuretic, and an angiotensin receptor blocker. And she had a complete remission of proteinuria in 2007, as you can see on the slide here on the right. Now, I do not claim it is because of that, let's say, a strong anti-proteinuric treatment. Still, the patient and I were happy. She did not require immunosuppression. Now, the honeymoon is not forever. As you can guess from the next slide here, you can see that the proteinuria went up from remission to again 2, 3, 4, and even 5 grams. So as a last resort, I started the pentoxifylline, which is an anti-TNF agent, very little low-level evidence, no ME impact. And then I thought, I don't know what that lady does have. Maybe I should consider, I should have thought about that earlier. Maybe I should have requested or considered a second kidney biopsy. So I did that. And at that time, it was my younger colleague, now Professor Nathalie Demoulin, who did it. And as you can see, the slide with the biopsies here. And this is all except minimal change, of course. It's an immunofluorescent. There are typical granular deposits, typical of membranous nephropathy. Now, what we did was to look back, because as a university hospital, of course, any biopsy material by law should be kept for 30 years, but for research, if we can keep it for 100 years, we will keep it, at least the blocks, and we did so. So we performed a reanalysis of the first, stored for 34 years kidney biopsy. And then I was a bit nervous because the diagnosis came in rapidly. It was a membranous nephropathy. So the initial diagnosis, probably there was a technical with the antibody serum used for the biopsy for the immunofluorescence. I don't know the answer, but anyway, I'm sure from the second and the reanalysis of the first biopsy that the first diagnosis was wrong. And then I thought this is membranous nephropathy. Maybe I should perform, which was already available in 2013. I should perform anti-PLA2R testing, and it was strongly positive. So I've learned from that from time to time in many fields of medicine, but also for glomerular disease, you should be ready to reconsider your diagnosis. And here the final diagnosis was an autoimmune membranous nephropathy. She got a short course of Ponticelli, so steroid cyclophosphamide alternating for 3 months. Then anti-PLA2R became negative. She had a complete remission of proteinuria, and that persisted until 2015. Since then, she had 2 relapses, and both were easily managed or treated with the monoclonal anti-CD20 rituximab. The fourth lesson I would like to convey to each of you is that from time to time, if you don't know the correct diagnosis, because you have never seen a disease and you have asked an expert and nobody is able to help you, you should be able to reassess the diagnosis in light of the recent literature. An example, a lady born in 1973, at the end of her 3rd pregnancy, she had a nephrotic syndrome. The kidney biopsy performed in 2005 showed, I will not show the detail, but believe me, the protocol was immune complex membranoproliferative, that's no longer the current wording, but membranoproliferative glomerulonephritis. She got supportive management, did well for some years, then had a relapse with a nephritic, severe nephritic syndrome and acute kidney injury. And she had a second biopsy because we did not understand what was on the hand. And then we found, because that entity had been described, that she had a monoclonal gammopathy of renal significance, described some months earlier by Fernando Fervenza and the team of the Mayo Clinic. We asked Fernando what treatment he would recommend. He recommended rituximab. She had a spectacular response to rituximab and is currently doing well more than 10 years later. The next point is how to assess or evaluate for albuminuria or proteinuria. Now, I will, of course, as a KDIGO co-chair, not disagree with the KDIGO guidelines, the CKD guidelines saying that the best is, if available, albumin to creatinine. Second, less desirable, but still very good, protein to creatinine. Third is a strip urine analysis with automated reading, and fourth is a manual or visual reading of a strip. That being said, if you follow patients with immunosuppression for a glomerular disease, the question that you should ask yourself is protein or albumin creatinine ratio or spot urine optimal for follow-up, maybe for important clinical decisions? I don't think so. This is a New England paper from 4 decades ago, where you can see that there is, as you would expect, an excellent correlation between, on the abscissa, the 24-hour protein excretion, and on the ordinate, the P/C, protein over creatinine ratio. Of course, there is an excellent correlation, but there is a scatter. So, in other words, there is not uniformity, and some patients may have, because the urine is more diluted or not, some patients may have a P/C that is higher or lower than the regression line of the 24-hour urine. So my recommendation is, if you want to make an important decision, if you have a patient under immunosuppression, I would still recommend, and I think many experts in Europe, I'm well aware that our US colleagues have given up. I know having a reliable 24-hour urine is complex. As I say in the slide, most patients at my outpatient clinic succeed in doing that well. I educate them, but I agree it's a question of education. Some patients, of course, will never succeed, and you get a little bit of everything. incomplete, more than complete, 12 hours, 48 hours, and you don't know how to interpret that. If that is the case, of course, a ratio protein over creatinine is much better than an unreliable 24-hour urine collection. But if you want to discuss reducing, starting, modifying immunosuppressive drugs, I still prefer the 24-hour urine if available. A next point to be discussed is what you do with persistent residual proteinuria, and you have the impression that the target disease, the glomerular disease, is inactive. Let's take an example of membranous nephropathy. Anti-PLA2R was positive strongly. The patient got immunosuppressives, and the anti-PLA2R is now negative. She had no edema, blood pressure under an angiotensin receptor blocker because she had coughing under ACE inhibitor, and she has proteinuria of 2 grams per day. Serum creatinine is 1.7. What do you do? And these are, of course, all except rare patients. And the same might be true even though this is not treated by immunosuppressive. If you have someone with diabetic nephropathy, what do you do with residual proteinuria? You do your best to treat the blood pressure. How can you improve the control of proteinuria? Well, you will remember that the renal trial from Barry Brenner 20 years ago in the New England showed that losartan did better than placebo. That's well known to reduce the risk of end-stage kidney disease. And that is largely due to the fact that the losartan reduces on the right-hand side, reduces the proteinuria by some 40%, whereas the placebo did not change at all the proteinuria. Now, what may be a little bit less well known is the fact that if you want to have the so-called antiproteinuric effect of ACE inhibitors or ARB, in my opinion, and based on evidence, no difference. If you want to get the reduction of the proteinuria with, on this slide, lisinopril, this is a study from 3 decades ago from the Groningen team, and I will show you 10 patients, very small size study, still published in Kidney International, and they started with 10 patients with glomerulonephritis. 3 days after each other, they have between 6 and 7 grams a day of proteinuria. Under low salt and the old alpha-methyl dopa, the drug still widely used for hypertension in pregnant women. Then they switch from low salt methyl dopa to low salt lisinopril, and the proteinuria decreases from 6, let's say, to 3. So it's reduced by, like in the renal study, by something 40–50%. What may not be well known is that if you keep the lisinopril, and they did that in that study, but they enriched the salt intake, the proteinuria goes back to the alpha-methyl dopa level. Then they reduced again the salt intake, keeping the lisinopril, and the proteinuria goes again to 3 grams. So 6, 3, 6, 3. What is the difference between this, that, and this? Just one thing, the salt intake. So I cannot see, salt is, we are in the Netherlands, is really low salt, 50 millimoles, so 3 grams salt. High salt was 212 grams, more Western-like, if I may say so. But 50 is not easy to obtain. And if that is not enough salt restriction intake, they showed in a subsequent paper in NDT 25 years ago that if you add hydrochlorothiazide to the previous high salt intake and ACE inhibitor, you will restore the antiproteinuric effect of the ACE inhibitor, because as you can see, in almost every single patient, and overall it was significant, except one, in almost every single patient, the proteinuria decreases when you add an hydrochlorothiazide. And there have been meta-analyses showing convincingly that if you reduce the salt intake, you get more reduction of proteinuria than if you do not. So ACE inhibitor or ARB, do not forget about the salt restriction of the diuretics. They are only fully effective if the salt intake is restricted and or with diuretics. What I'm personally doing, I advise the salt restriction. Now I'm treating human beings, not animals, not experimental animals, rats or mice. So I know well how difficult it is to follow a salt restricted diet. If available and if the patient is able to perform 24-hour urine connection, I will check 24-hour urine for sodium to see whether the salt intake, if out equals in, how much is the salt intake. It's a very rough estimate, but it gives you at least some idea. If the 24-hour proteinuria is still above target, I add a diuretic and I uptitrate, even in the absence of edema or hypertension. The limiting factors to that strategy are sometimes a low blood pressure, but if you educate patients and you tell them that it's not a disease to have a systolic blood pressure of 110 or 100, most will have no complaints at all. And second, muscle cramps. Now the muscle cramps, it's volume, it's not potassium, calcium, or magnesium. It's exactly the same as what people have during a hemodialysis sessions. It's volume sustraction. And if you restore the volemia by reducing a little bit the dosage of diuretics, the muscle cramps will improve rapidly. Here is an example of a patient with diabetic nephropathy in whom I decide to start a furosemide, so a loop diuretic. He had already irbesartan. As you can see, the serum creatinine went up from 1.5 to 3. Now, he was nervous. I was not, because at the same time, the proteinuria 24-hour went down from 3 grams to 0.5 grams and stayed around that level. And after the investment here is in red. If I'd done nothing, the natural history of the serum creatinine would have been in green. It would have been went up, blood pressure was not well controlled, he had edema and high proteinuria. We made an investment which is in red here, and the return on investment, I am not a Wall Street specialist, but the return on investment is shown here in yellow. Now, as you can see, the area under the curve in yellow is by far larger than that of the investment in red, so there is no doubt this patient benefited, even though temporarily the same serum creatinine went up. Now, should you do dual blockade with an ACE inhibitor and an ARB, there have been 3 studies, all randomized, that have time to answer that question. I will briefly mention the 3 ones. The first one is the on-target study by Johannes Mann from Munich in Germany, showing more problems with the combination of telmisartan and ramipril than with a single drug, either telmisartan or ramipril, more acute dialysis, more hyperkalemia. The second study by Hendrik Paving, aliskiren combined with angiotensin, an ACE inhibitor or an angiotensin receptor blocker, more hyperkalemia, more AKI, no benefit. The third study, the study of Linda Fried from the VA in the US in diabetic nephropathy, again, more problems and no benefit. More problems, AKI, hyperkalemia, with the combined double blockade, if I may say so, than with the single blockade. So, of course, I strongly believe, as you understood, that nephroprotection, reducing proteinuria with medium to long-term drug treatment is extremely important. Still, you should not underestimate the risk of AKI or hyperkalemia. And so, yes, and the guidelines, KDIGO guidelines say yes, RAS blockade, but a single agent. Now, of course, if the patient has heart failure, you may add to that a low dose of spironolactone. Lastly, and this is more recent, as you certainly know, if that is available in your country, if you consider ACE inhibitor ARB, there is residual proteinuria, do not forget that you should give the preference to ACE inhibitor or ARB plus an SGLT2 inhibitor, but I'm sure you have heard about that. We can come back to that during the discussion. The 8th lesson is that if, and there is a specific mention at the bottom of every letter we are writing to patients and to GPs, so primary care doctors, we always warn the patient to stop temporarily the ACE inhibitor or the ARB and the diuretic in case of intercurrent illness, such as a severe gastroenteritis or other severe pneumonia in the elderly. They will eat and drink very little. They may then have functional acute kidney injury that has been mentioned in the KDIGO guidelines, the 2012, the CKD ones. I've said that for 15 years. That does not mean that I do no longer see functional AKI in those under ACE-inhibitor ARB who have gastroenteritis. But in those who stop it, I'm convinced I cannot demonstrate that. There has been no randomized control trial, but logics, reasoning recommends to stop temporarily if you have acute gastroenteritis. And the benefit of reducing proteinuria is anyway maintained because the benefit is dependent on the area under the curve of the proteinuria. If it decreases a little bit during a few days, that does not change the benefit. I'm coming to the last 2 points of my talk, and I'll be happy to discuss with you. The 9th point is, I personally, at least as long as you are at a low dosage of immunosuppressive drugs, I personally go slow when withdrawing immunosuppressive drugs. I just want to stress that having no evidence for a benefit of long-term immunosuppression, and some of the glomerular KDIGO guidelines may say that you should continue, for instance, maintenance therapy for ANCA vasculitis for 2 years. Okay, I agree. They do not say that you should stop in every single case after 2 years. I will just show you an example. Now, I'm not kidding. That lady 20 years ago was 18 years ago, sorry, was 78-year-old. She had a diagnosis proven by biopsy of ANCA positive, MPO positive necrotizing glomerulonephritis, somewhat unusual with polyclonal activation, rheumatoid factors, etc. She got the classical treatments at that time, steroids, cyclophosphamide, 6 intravenous boluses, and then maintenance azathioprine. That was very well tolerated, of course, because she was already 78 years old. I was cautious and we reduced the immunosuppression. She had a complete remission, CRP was normal, ANCA were low, MPO titer was low, but not negative. And after 10 years, I thought I will completely stop methylprednisolone. She was on 2 milligrams a day or something like that. And then I decided to stop azathioprine. Now what happened? She was at that time 88 years old. She was in an excellent condition for her lifetime. 6 months after azathioprine withdrawal, she had a recurrence of heavy hematuria, worsening EGFR, high CRP, rapidly rising ANCA titers. I did not decide to perform a second kidney biopsy. She got methylprednisolone 32 milligrams for a week, then 16 because of her age, of course. I stopped methylprednisolone in 2 months. She had a few pulses of cyclophosphamide, and then azathioprine was restarted. I will never stop again. She is now 96 years old. She had a complete remission. She is coming by metro at my outpatient clinic. Of course, she's an exception at her lifetime, but she did well. And I've learned from that case and many others that, okay, tapering the immunosuppression slowly, there is always a time to stop, but if you stop, keep in mind, there may be, even after years, a relapse in some diseases. Lastly, and I would like to stress, this is probably the most important thing I've learned in my career in terms of glomerular disease. Whenever possible, I try in the follow-up of complex cases, and the natural history, I will show you an example, the natural history of glomerular diseases is, let's say, relapsing, remitting, not easy to predict. That is true for minimal change, that is true for FSGS, that is true for membranous nephropathy, but also for ANCA, lupus, and so on. So the evolution is poorly predictable. It's like an equation where you have a single equation and 2 unknowns or 3 unknowns, so it's already complex. Now, there is no need and even potential harm, in my opinion, to reduce the predictability by making multiple changes at the same time unless it's very urgent. So I have learned that after learning that, I decided to never withdraw an ACE inhibitor and reduce the immunosuppressive regimen at the same outpatient clinic. I rarely change 2 immunosuppressive drugs at the same time, again, unless it is very urgent. And I show you here a pediatric case, not from my practice, but I could have shown several. But I could have shown only where I changed one thing at a time. The message I want to convey to each of you is that if you have since a year no change in treatment, same very low dosage or no immunosuppressant, same antiproteinuric treatment, and you have a relapse, then there is a good reason, if the relapse happens after the last change, very recent one, that it is due to that. If you change multiple things at the same time, you cannot understand what you are doing. Here is an example of a patient with FSGS. She has no treatment, initially, well, some proteinuria, but not major. But here, 16 grams proteinuria, high dose steroids, some improvement, all except impressive, started on cyclosporine, not very impressive. And after some time, no impression that cyclosporine helps. So cyclosporine by my pediatric colleague was stopped and an ACE inhibitor was started. And then she tried something else and started tacrolimus, another CNI, as you know. The trough levels were around 6 to 7. Now she had no impression of improvement, stopped tacrolimus, started an angiotensin receptor blocker, some fluctuation, then she restarted sometimes later, tacrolimus again. Now you might say here, when she restarted tacrolimus, oh, miracle, albumin level went up from 21 to 33 and 35, and here from 9 to proteinuria 9332. Let's say at least a very good partial remission. But you will see on the next slide then when she stopped the tacrolimus, well, nothing happened. And nothing happened, and neither for the 24 proteinuria nor for the albumin level. Suggesting, again, not demonstrating, this is a single case, but suggesting that the tacrolimus was not the reason for the improvement. But at least if you have a single change, you can try to understand what happens. If you make 3 or 4 changes in 2 months, forget the aim to understand what is going on, unless it's clear-cut, complete remission. Otherwise, it will be hard to understand why, what happens. So what did I say to summarize? I think number one, the first lesson in that making all possible efforts to have a correct diagnosis in glomerular disease. The second biopsy, expert opinion images is certainly worth efforts. Second, a kidney biopsy is very important, not always the single key point, the whole picture, the family history, the urine test. Third, you should be ready to reconsider the initial diagnosis if the picture over time does not fit. And then I've shown you an example of wrong diagnosis in my hospital. Fourth, you should be ready to refine the unclear initial diagnosis because a new entity has been described in the literature. So if you have unresolved cases, keep them in a box, if I may say so, and from time to time have a look at PubMed to make sure that that entity has not been described. Fifth, prefer 24 proteinuria if feasible. Sixth, restrict salt intake and or steroid diuretics even in the absence of edema, hypertension. 7, beware of double RAS blockade, but please do not forget adding, if available in your country, SGLT2 inhibitors. 8, warn the patient to stop RAS blockade diuretics in case of severe gastroenteritis or intercurrent illness. 9, go slow when changing treatment regimen unless very urgent. And lastly, one change at a time in order to increase the chance to interpret correctly the impact on change versus the natural history of the disease you are treating. And with that, I would like to stop here. I just want to thank my colleagues from the current team, senior team. All of them are younger than me, of course. You may know some of them, Eric Goffin on the left-hand side, Nathalie Demoulin, Johan Morel, Nada Canan, Valentine Gillon, Laura Labriola, and Arnaud de Vest. I have pleasure to work on a daily basis with them. And with that, I thank you for your attention. And in contrast to what is on the slide, I do hope there will be time for questions. So thank you for your attention, and I'll be happy at least to try to answer your question. Thank you. maybe I'll shut down temporarily my microphone. Or...
All right. Dr. Fried, are you there? Can you take the second part?
Yes, I am. So
Yeah.
thank you very much, Professor Jadoul, for the excellent presentation. Please accept our thank. And I would like to chair now the second session for the question, comments, discussion from everyone. I would like just to acknowledge the presence of our senior nephrologists, professors from Muhimbili University, Professor Pascal Rugajo and Professor Francis Furia, also from KSMC University. We have Professor Kajiru, together with senior nephrologists from all over the country, and also from Kenya. I can see doctors from Kenya, Jonathan Wala and Ahmed Twahir, and from Ghana, Dr. Elliot Turner. So I'd like everybody who would like to speak, please, you can raise your hand and then we can give you a chance. Professor Rugajo, I can see your mic is on. Please, you are welcome.
Oh, thank you so much, Dr. Frida. Merci beaucoup, Professor Michel.
Avec plaisir. Go on, yeah.
Yes, it was really nice to hear you from the beginning. And you are very articulate, very good to hear from you, and very memorable 10 commandments when dealing with glomerulonephritis.
There may be others, but at least these are the main ones in my opinion. Yes, go on.
Okay, thanks. So we started humbly kidney biopsying here in 2012.
Yeah.
We have now 10 years experience, and we one day hope to be able to share our experience for the last 10 years. But precisely, I have two questions to ask. When you meet adult patients with nephrotic syndrome, is it okay or is it clever to assume that probably it is minimal change disease and start steroids like we start for children? Or is it clever to do kidney biopsy right from the start?
Yeah, okay. My reply will be balanced, if I may say so, because you mentioned that you have now 10 years experience. On the other hand, I know a kidney biopsy, there is a small risk, there is a cost, etc. So my reply would be, I would certainly, I mean, it depends on the definition. In children, of course, it's a classical practice not to perform a biopsy, to treat with steroids and see what happens. Maybe I would consider that depending on the context, the pros and the contrasts, and you have to decide eventually, because you know the context. I just can give my opinion, but unless you have a young adult, because the epidemiology is such that the older the patient, the less the chance of having a minimal change. In someone who is 60, minimal change is probably something like, it exists, but it's probably something like 10%. And most cases will be membranous or other more severe diseases like AL amyloidosis, like MGRS, like depending on whether there is hematuria or FSGS, etc. So maybe I would consider in a young adult, if it is difficult to have a kidney biopsy, the patient is living remote and you want absolutely to avoid, and okay, you give a course of 4 weeks or 6 weeks steroids and you get a full remission after 2 weeks, which in a young adult is not unusual. Well, if you have a full remission after 2 or 3 weeks, that's a reasonable, let's say, decision. But if you don't get the remission after, let's say, 4 or 6 weeks, I would certainly do a biopsy, and I don't think I would start steroids without biopsy in someone older than, well, what is being young or very young. I would say in someone older than 30, and 40 is still young, 50, I'm 64, that's not a secret. I still consider myself as relatively young, of course, older than younger people. I would not start steroids without biopsy in someone older than 30, because the epidemiology is such that but that's, it's easy for me to say I need a biopsy because I will get it. So you should integrate that into your context.
Thank you so much for that answer. Very practical. Now, my second question, a few weeks ago, I encountered a middle-aged woman, HIV positive, with a single kidney. She had nephrectomy several years ago,
Yeah,
for unrelated cause, but she has had persistent subnephrotic proteinuria, always between 1 gram and 3.5 grams, in between there, but not nephrotic range.
yeah.
Would you biopsy that patient?
Yeah, just to make sure that, because from time to time the line is not, to make sure that I understood, what is her, she is HIV positive, correct, or did I misunderstand?
No, she is HIV positive.
Okay, so I understood correctly. Yeah, okay.
Correct.
Well, I would say the following. What I would do, an HIV sub-Saharan African patient, even in Brussels, I mean, she's of course treated for HIV disease. I assume that that's the most important point. And she's under antiproteinuric treatment. I don't think I would put more emphasis on getting an SGLT2 inhibitor, but having a proteinuria of 1 to 2 grams, if there is no hematuria or very little, I don't think that having a biopsy whose risk is not zero, not very high, but not zero on a solitary kidney. I've done that a few times on a solitary kidney, but I've done that only when there was subacute kidney failure, and I wanted the answer absolutely, because one was a suspected acute interstitial nephritis in a single kidney. Now I got the reply, there was a huge infiltrate. I had, fortunately, or the patient did not have complications. I put steroids and she recovered. We had more recently a patient with a junction phenomenon who lost one kidney, and she had C3 glomerulonephritis, suspected based on low C3 level, and again, severe AKI. And we decided to have a kidney biopsy, which confirmed the diagnosis. She is now at the border of dialysis, but was able to live with immunosuppression without dialysis for 4 or 5 years, I think. So sometimes the risk may exceed sometimes the benefit of the biopsy may exceed the risk. But here, if I'm hearing correctly, with a proteinuria, let's say around 2 grams, I'm not sure I would feel, but that's again opinion based, of the old professor with white hair. I don't think I would believe that the benefit exceeds the risk. So I would tend to say, I would try to again look to see whether we can improve further the treatment of the proteinuria. I'm sure you have done a lot, but I would probably not do the biopsy.
Thank you. Thank you so much.
Thank you so much. Thank you, Professor Rugajo. Anybody else would like to comment before I go reading the questions in the question and answer session? Okay, Professor Jonathan Walla from Kenya, you're welcome.
Thank you very much. Maybe Dr. Lloyd can go ahead of me because he was waiting us in the queue. Dr. Lloyd.
Yeah, thank you, Professor Jadoul, for a very interesting lecture. My question is it being clever to take a third specimen when we're doing a renal biopsy for electron microscopy, just in case the light microscopy and the immuno are not very useful? Because routinely most doctors, when they do a biopsy, they just take 2 specimens and then they get stuck when they have no much information, then they have to call the patient again. So what's your recommendation?
Yeah, very, very good question. I did not discuss that specifically. What we do, we obtain 2 specimens, one for the light microscopy and the other one is frozen and is initially used for the immunofluorescence. Now you might use it for immunohistochemistry depending on what your hospital or what your pathologist is using. Now, for the electron microscopy, if you have a reasonable size of frozen specimen used initially for immunofluorescence, you will be, let's say, you will try not to use the whole second specimen for immunofluorescence, and a small piece usually is enough to have a few glomeruli and being able to do electron microscopy. Of course, as you know, the problem is that electron microscopy is less fast to get the result than the other techniques. But yes, it's definitely from time to time, electron microscopy is critical. In some large hospitals in the US, it's routine. We try to get it every time, but we do not, to be honest, because our pathologist is very busy. But from time to time is critical. So having at least in mind that you may need to have a small piece, we use a part of the second specimen because of the risk. Anytime you puncture, you have a small risk. So we try to avoid a third puncture, but electron microscopy may be critical. I hope that answers your question. And it may be dependent on the size of the two pieces you already had. If the size is quite good, that may be enough. If the size is small, you may need a third one to make sure you have everything with a single biopsy and not a second one a few weeks later, of course.
Professor, thank you for your very practical presentation regarding the safety. I'm just saying that when you're giving immunosuppression for biopsy confirms the condition which is responsive to it, and the patient is still progressing towards end-stage renal disease, when do you give up? That's my first question. When do you give up on immunosuppression once you realize that there is worsening GFR? And the second question is a follow-up to your suggestion about SGLT2 inhibitors in glomerulonephritis. For somebody with a nephrotic syndrome or nephritic nephrotic syndrome, when will you start an SGLT2 inhibitor? Will you start them with the S inhibitor, after, or even before? Thank you very much.
Yeah, again, of course, a highly critical and perfectly sound question. I think the answer is, if I may say, it may sound like a joke, but it's both simple and complex. I would say it's not a decision based on the single component. I would make a few comments. Number one, the slope. The more it's progressing slowly, the more you know that if you are late, meaning with a low GFR, and it has progressed slowly, the more you know there will be extensive, even without biopsy, there will be extensive scars in the kidney, and so there is no hope that you will go back and improve. So I would tend to give up earlier if there are extensive scars in the biopsy and or the slope is slowly progressive. And of course, the more the disease is advanced in terms of low eGFR, the more eGFR is low, the more I would be cautious not to kill the patient with immunosuppressants. So slope is one. Number two, not fully linked to the previous one, is hematuria or not. I mean, it's not the same disease diagnosis. ANCA vasculitis or lupus usually respond, not all of them, but many of them will respond very well to immunosuppressant. FSGS may be more resistant in a number of cases. Membranous, if you are able to have PLA2R titer and the patient is PLA2R positive, you have a way to know whether the disease is still immunologically active. Is the PLA2R antibody level in blood positive, or is it negative? If it is positive, at least it's a reason to treat. If the PLA2R is negative, that's a reason to reduce the immunosuppression and order again another PLA2R level some months later and see if again the PLA2R is negative. It means that the disease is inactive and you will not get benefit in membranous PLA2R positive, of course. For the cases that are PLA2R negative, it's more complex to decide. So what else? Also, biopsy picture, markers, meaning PLA2R for membranous. It may be complement or anti-DNA for lupus. It may be ANCA titer for vascular. If all markers are negative, I would taper the immunosuppression and follow the markers in blood, in urine, and of course the GFR. What else? So your question is very broad. I've put forward a few points. I think the slope, the scars, the disease diagnosis, and lastly, or there may be others, and other people should feel free to comment. Of course, the side effects. If someone is tolerating very well steroids, of course, we all know nobody tolerates perfectly steroids for years. There is always side effects. But some patients may get earlier side effects than others. Some patients are older, others are younger. So the balance between the pros and the contrast may also be dependent on the side effects, whether the tolerance of drug treatment is okay or not. These are a few ideas that come to my mind. But again, I do not claim this is complete. Maybe I forgot something.
Thank you very much. Well understood. The second part of the question is SGLT2 inhibitors. When will you commence them? With proteinuric from nephrotic syndrome, there being no good evidence as such yet. So we expect that maybe evidence will come in later on that say the benefit for using SGLT2 inhibitors. So will you commence them with the S inhibitor when you're starting it, or when the S inhibitors are not working so well, or at what period of time?
So again, the line was not perfect, but I think your question was about SGLT2 and or ACE inhibitor ARB. Now let's clarify. The first line of the treatment of proteinuria, be it nephrotic or not nephrotic, proteinuria or albuminuria, if you prefer, is an important target and therapeutic target. So it should be treated in any patient with chronic kidney disease. Number one, at least significant proteinuria. Certainly albuminuria according to KDIGO A3, certainly, and maybe A2. Of course, A1 is normal. Number one. Number two, ACE inhibitor or ARB. Well, SGLT2 inhibitors should be added. Well, in severe nephrotic syndrome, in patients under immunosuppressive agents, those were excluded from the, let's say, for instance, the DAPA-CKD trial or the coming EMPA-Kidney trial should be presented probably at the ASN in Orlando in some months. I don't know yet, but I suspect so. Anyway, in DAPA-CKD, you may have seen a subgroup analysis of something like, if I recall well, 80 IgA nephropathy patients who were not nephrotic but had severe IgA nephropathy with progressive chronic kidney disease. And they respond very well to SGLT2 inhibitors. So in those, now, is it complementary to immunosuppression? Sometimes. But I will try, as I mentioned, firstly, if I decide to give immunosuppression, I will try to use it and see what happens. If the disease is inactive, or I believe the immunosuppressive agents are more against their use than in favor of their use, then I will start an SGLT2 inhibitor. You may start it all together the immunosuppression, but that was not the topic of the DAPA-CKD study, because those with, let's say, vasculitis or glomerulonephritis under steroids, high dose, were excluded from the DAPA-CKD. But there is no reason, there is not a benefit. But that's again reasoning, not hard evidence. I strongly believe SGLT2 will become the second line of the backbone treatment of proteinuric CKD, whatsoever the cause, if I may say so.
Thank you very much, Professor.
Thank you. So moving to the question and answers session, I'll start reading the first question from Dr. John Philip Mumbi. He's asking, with difficulties to control salt intake, can we instead use combination of ARB and hydrochlorothiazide and get a desired effect of reducing proteinuria?
And to make a long story short, the answer is yes. If, of course, any drug has some side effects and you have a thiazide, you may decrease a little bit the glucose tolerance. You may have also a somewhat higher risk of gout, because uric acid will go up, but still treating correctly proteinuria is so important that if I see, usually it's not urgent, so I do not start everything initially. I will start an ACE inhibitor or an ARB. I will strongly advocate salt restriction. If I see it's not correct or the proteinuria remains too high, I will not wait for a year before starting a thiazide. Yes, I would do that, definitely. It's a cheap drug, it's widely available, and it helps.
Thank you, Professor. The second question is from Dr. Mazal Amirali from Muhimbili National Hospital. He's writing, thank you, Professor, for this lovely, concise presentation. I have a patient with most likely diabetic nephropathy, clinically, not biopsy proven. He is hypertensive, blood pressure now well controlled, less than 130/80, and HbA1c is 9%. His creatinine is normal at 82 millimole per liter, and he has proteinuria of 3+ and hematuria 3+ on dipstick. He is already on telmisartan twice daily and on empagliflozin 10 milligram daily. My question is, should I biopsy this patient to confirm the diagnosis of diabetic nephropathy, or perhaps another glomerulonephritis? Or should I give beta glycemic control a chance? He's also on metformin, sitagliptin twice daily, insulin, glargine 40 units at night, and gliclazide extended release 60 milligram once daily for his diabetes management.
Okay, so if I understand correctly, I think the summary was clear. I would summarize as follows. Normal GFI, but still, let's say, glomerular proteinuria around 3 grams. And what is, in my opinion, very important is the extent or the amount of hematuria. I'm hearing on the dipstick +++, which is not normal, but not huge, because the dipstick is very sensitive. So I would like to know a little more about the extent of hematuria. The more there would be a lot of hematuria, the more I would not be perfectly comfortable with the idea that it is diabetic nephropathy, because I see, like you do, we all see many patients with suspected diabetic nephropathy, and the vast majority of them have little or no, very little hematuria. So there is really, it depends on the definition, and you should know your lab values, preferably under the microscope than just the dipstick, but that would play a role in my decision. If there is overt hematuria, I would seriously consider a biopsy, just because there might be something else. If there is little hematuria, a second point would be, do you know something about the past? Because treating the glucose is of course important, but when the kidney disease is at the level of macro, so-called proteinuria or albuminuria A3, the most important points are blood pressure, treating albuminuria or proteinuria, SGLT2 inhibitors. Treating the glucose or the HbA1c is important for the general health of the guy or the lady. Will it help at that stage the further deterioration of the kidney function? I'm not so sure. I try to answer at least partly. Any further question, welcome on the chat or orally.
Thank you. Dr. Mazhar will ask if he has another question.
Yeah.
Now we are moving to Renal Association of Mauritius. The question is from Dr. Davy. He's asking, we have a 12-year-old girl referred to us from the pediatricians, nephrotic syndrome from the age of 18 months, have been treated with steroids, cyclophosphamide, and MMF, each time with response for some time, but eventually with relapse. She had an episode of relapse with acute kidney injury, creatinine to 200 in December last year. Settles with steroids and tacrolimus, and creatinine went back to normal. Recently, she relapsed with creatinine back to 200-ish, 11 grams per 24 hours protein. She has just been biopsied, and initial light microscope shows FSGS, awaiting immunofluorescent and electron microscope from a broad lab. How should she be treated?
Okay, so these are, I have a number of such patients who have had nephrotic, let's say relapsing nephrotic syndrome. You may call it minimal change or FSGS, but as long I'm not convinced, there is some evidence there may be differences, and recent evidence from the group of Astrid Twins in Boston that a subgroup of minimal change disease may have minute deposits of IgG along the basement membrane. That's last year ASN and published in JSON anyway. The key point, and the description is excellent, the key point is that anytime there is immunosuppression, there is full remission, if I captured correctly. That's critical, meaning the disease is responsive to the immunosuppressive. Of course, the concern is the burden of immunosuppression in an, if I understood correctly, an adolescent now, 13 years or something like that. Did I understand correctly?
Yes, 12 years now.
How much?
12 years.
12 years, okay.
Old girl, yeah.
Yeah, okay. So I would say if I would have no resources problem, and that's the next point, I would seriously consider rituximab. I've had a number of patients with multi-relapsing minimal change, sometimes FSGS primary, I mean full-blown nephrotic syndrome, in whom, and there is literature about that, I cannot speak in such a talk about everything, but I have a patient who has relapsing minimal change disease now since 1990. We are in 2022, so more than 30 years. She has 20 episodes, and the last 5 ones were treated by courses of rituximab, and now she follows her urine tests, and whenever she sees that the urine testing is on the rise, she sends me an email, comes to the hospital, gets 2 infusions of rituximab, and rapidly gets again a remission. So that's at least one way to consider. Now, I'm not a pediatric nephrologist. I don't think there is a clear contraindication to the use of rituximab in adolescents or young adults, 12 years, or adolescents, or children. But that should be checked. But I would be in favor of that, because the side effects of the other drugs that have been used and that gave good results are, if you give them repeatedly, well, no. And rituximab, at least my patient, the one I mentioned, who has got 20 episodes, she now gets rituximab every 2 years, which is not a huge immunosuppression burden. And during those 2 years, she's off any immunosuppression, does not need anything. And then she gets again a relapse and comes to the hospital and again gets a full remission with 2 grams of rituximab.
Thank you.
Happy to discuss privately by email if helpful, but I would seriously consider that.
Okay, thank you. We have another comment and question. He's asking how to withdraw immunosuppressive agents in patients with a slow decline in EGFR versus patients with a rapid decline in EGFR.
I'm trying to find the question on the chat. I'm not
In
sure.
the question and answer session, it's at the bottom.
So-called discussion. Oh yeah, no, I missed
Q&A,
that.
Q&A.
Yeah, okay,
Last.
I see. I'm going down. Kindly go through how to withdraw immunosuppressive in patients with slow decline versus patients with rapid decline. Well, I think the answer cannot be based only, in my opinion, on the slope, because we are back to what we discussed some minutes ago. It's not just the slope. The slope is one aspect. The second point is whether there has been a response, partial, complete. How is the urine testing? So I would not decide based just on the slope. Of course, the slope is something, but the slope, the diagnosis, the biopsy result, the response of the urine testing, everything, and preferably sequentially. And if you, of course, not the biopsy multiple times. I would base my decision on a number of items, not just one, because I would be unable to say. And if you have a serological marker, as I said, PLA2R or complement or ANCA in some other disease, that may play a role as well. I think that's the best answer I can give, meaning the question is probably good and difficult to answer. I hope it helps.
Thank you, Professor. Now going to the chat box. I will start with the question from Dr. Jonathan Mungumi from Muhimbili National Hospital. He's saying, thank you very much for the nice presentation. Prof, do you do protocol biopsy for post-kidney transplant recipients in your center?
Yeah, I'm not a transplant nephrology, but I'm able to answer the question, which is a good one. The answer is no, we did that a decade ago and then stopped for a number of internal organizational reasons. We hope to restart soon. I think the protocol biopsies, there is no, to the best of my knowledge, but I'm not a transplant nephrologist, so I should state that very clearly. But generally speaking, what I would say is that there is no clear, there are some clues that it may help in the management. There is no overt demonstration that it is a must. Otherwise, any kidney transplant center, we perform 90 kidney transplants a year. Any kidney transplant center should do them. We do not currently. But it's a wonderful research tool. And from time to time, it may help. But there is always a small risk, even though a graft biopsy may be somewhat less risky than a native kidney biopsy. So to make a long story short, the answer, at the moment, we do not.
Thank you. So we have another question from Dr. Masimango Imani. I think you are familiar with him. Thank you, Professor Jadoul, for this practical presentation. Kidney biopsy without IF or immunohistochemistry is still a problem in many settings in sub-Saharan African countries. What's your option about the only option, which is optic microscope?
So Manix, if I understand well, your question is, are you happy? I will be a little bit making a joke. Are you happy with only light microscopy? And I'm sure, because we have been working. Go on. No, happy. I know you would prefer to have both. I would say that for some diagnoses, it may be good enough, but stage 1 membranous nephropathy, you just see it by immunofluorescence. And so if you see a normal glomeruli by light microscopy, it may be stage 1 membranous nephropathy. There are small membranous deposits of immunoglobulins or immune complexes, and you don't see that in the very early stage by light microscopy. So there are a number of diagnoses, and second, you will never know whether the deposits in the kidney, for instance, are clonal kappa equals to lambda, or kappa more than lambda, which may put at least suggest a clonal disease, a B-cell disease. So there are a number of important aspects for which immunofluorescence or immunohistochemistry is most welcome. That being said, if you have a light microscopy, it's already much, much better than nothing, of course, but you will miss some diagnosis. I think that's the best answer I can provide.
Yes.
Thank you. And the last question from Professor Pasco Rugaggio of Muhimbili University. He's asking, what is your best protocol for rapid progressive glomerulonephritis for children?
I will say very honestly in that respect, I would refer you to the KDIGO guidelines. I guess there is one about RPGN for children. I'm not sure, but we had experts in the KDIGO GN. It has been updated, as you certainly know, and published in 2021. It's freely available both on the Kidney International website and on the KDIGO website, so do not hesitate to the KDIGO website. I'm not a pediatric nephrologist, and honestly, I've seen a few cases in adolescents of ANCA vasculitis. Of course, the question you should have in mind in that respect is the potential toxicity of cyclophosphamide, fertility problems, but at some points in children, ANCA vasculitis frequently, if it occurs, it's rare, but if it occurs, or RPGN, it may be very severe. So I would, of course, be concerned with the side effects, but I would try to first save the life and the kidney function of the patient. So, but I would really suggest you to go back. And if you still need more help, I would be happy to ask my colleague, Nathalie Godefroy from my university hospital to provide an advice on the case if you need so. My email, I did not mention that, but it's available on PubMed and otherwise the organizers. I will send a slide later today. I'm happy to interact if needed. Of course, not on a daily basis for 20 cases. I do not know everything very well, but I'm happy to help if I can.
Thank you so much, Professor. So I think we've finished all the questions. Now I'd like to hand over to Dr. Lloyd Vincent for closing up remarks.
Thank you very much. Thank you very much, Professor Jadoul. It's indeed a pleasure that we could have you here in East Africa. And it's a very rare opportunity to get luminaries in nephrology like yourself talking to us. And we had a wonderful session. And this is sheer experience of so many years that is concised into a little hour. And extremely grateful for the patient questions that you answered, and also glad that we have two of your products here in East Africa, Dr. Sylvian, who's also here, and Dr. Manix. Extremely grateful for all your support into Africa, and we're once again extremely glad and thankful that you were able to come and to talk to us. Thank you, Dr. Jadoul. We hope that you would again come, and not only that, we hope you would physically come out this side as well. So we would.
Thank you again. I would be more than happy to give, not next week, of course, or the week thereafter, but I would be more than happy to consider another talk in some time, and of course to meet face to face as soon as possible in East Africa or in Cairo next year for the Afghan meeting. Or I would be, as I mentioned, more than happy to come, but it should be planned, of course, in advance. And I wish you all the best. I've been happy to discuss with you important topics, and well, stay safe, all the best, and we keep in touch. Thank you.
Thank you, Professor. Thank you very much. Extremely grateful.